Good afternoon, ladies and gentlemen. First, thank you for coming and for your participation in this excellent symposium. And now we are going to start a panel about acute aortic dissection. We thought that in a cardiovascular care congress, it's very important to have not only the typical coronary patient, and we think that aortic acute dissection is an issue that could be of your interest. And we have the privilege to have three top level international speakers with us. My co-chair, Maria Lidón from Vall d'Hebron, Barcelona, and Arturo Evangelista, known for all of you. He's one of the most important experts in acute aortic syndromes with many publications, and one of the co-founders of IRAD. Also, we have a cardiac surgeon, head of the cardiac center in Vienna, Dr. Martin Grobenhauer, very expert in thoracic aortic aneurysm and aortic dissection. And finally, Dr. Nienaber from Royal Brompton in London, with high interest. He's also co-founder of IRAD, and with high interest in the acute aortic dissection and the non-medical treatment of this patient.
The first speaker is Dr. Arthur Evangelista. He's cardiologist, director of the Department of Cardiac Imaging at Hospital Vall d'Hebron de Barcelona. Since 20 years ago, his contribution in the image knowledge in the diagnosis and evolution of acute aortic syndromes are very important. Some of the referential articles has been written by him, and for this reason, he has participated in the last guidelines on aortic disease. He is the Spanish coordinator of RESA and the IRAD. He speaks in the 10 main lessons from 10 years of clinical collaborative research, IRAD and RESA register.
Thank you very much for the introduction. I would like to thank the organizer to include in this session of the acute aortic syndrome in this meeting. I think for us is very important, and I think for you also will be interesting. The International Registry of Aortic Dissection was set up in 1996 with 11 centers from 6 countries, and now there are more than 50 centers and more than 7,000 patients included with acute aortic syndrome. The first slide will be only to try to remark some specific aspects that maybe are not absolutely defined previously. And here we can see that that is the demographics and history of patients with acute aortic syndrome. And we see that the prior surgery is 17% of cases that was not in the classical publications, and we have also iatrogenic causes around 5%, similarly than Marfan syndrome. So that is a different etiologies that maybe 20 or 30 years ago. In addition, in the physical exam, we can see that the high blood pressure in the presentation is prevalent in type B dissection, and the other low blood pressure, shock, tamponade, aortic murmur, aortic regurgitation murmur, pulse deficits, and stroke is more prevalent in type A aortic syndromes. That is also important to point out that we have a C6-ray normal in around 20% of cases with type B aortic syndrome, so a normal C6-ray cannot rule out an acute aortic syndrome. The white mediastinum is present around 75% of cases, and in addition, ECG is abnormal with signs of ischemia or new myocardial infarction in this percentage of cases. So in some cases it's difficult to differentiate only for the electrocardiogram an acute coronary syndrome than an aortic syndrome. The IRAD proved the benefits of the use of this algorithm to suspect the acute aortic syndrome, because that the main point to have an early diagnosis is to suspect the presence of the acute aortic syndrome. So they define, as you know, different variables such as conditions, Marfan, previous aortic disease, valvular disease, recent aortic manipulation, or the pain that is characteristic, that is abrupt onset with severe intensity, rate pain altering. And in addition, there's some exam features such as a pulse deficit or differential systolic blood pressure in different arms, focal neurologic deficit in the presence of pain, murmur aortic insufficiency with a new pain and hypotension and shock. So we can see when we analyze in these patients from IRAD that height conditions was present only in around 30% of cases. This type of characteristic of the symptoms were present in 87% of cases, and this physical exam was present in half of the cases. But when they use the score 1, 2, and 3 all together, they identify that 0 score was only present in this series in 4% of cases. 1 of them were present in 36% of cases, and 2 or 3 were present in 59% of cases. So the overall sensitivity was around 95%, and the cases without 0 score, or with a score 0, when half of them had a chest X-ray, and the half of them presented abnormalities. So I think this is a good approach to think about the presence of acute aortic syndrome. The other important publication that generated high controversy is that in our series in the IRAD, 59% of cases had a maximum diameter in ascending aorta lower than 55 millimeters, and 40% lower than 50 millimeters, when you know the guideline recommendation to indicate surgery is 55 millimeters. So around 60% of cases, they didn't have enough enlargement of the aorta to indicate prophylactic surgery, and so that implies that maybe it's not only the diameter, but other factors that can provoke the aortic dissection. Regarding the diagnostic, we can see here in the IRAD and also in the Spanish registry that 72 or 78%, more or less similar, is used the first technique, the CT, and echocardiography around 20% of cases. Angiography is only residual, 1%, and MRI also is residual. So CT is the most used technique. And why? Because it's more available, and really the diagnosis of dissection often can be performed for a generalist radiologist, and maybe for using transesophageal echo, you need an expert for that. So it's more available. CT gives accurate morphological information, and also the wide field of vision of CT is significantly better than echocardiography. You can see here the entry tear, you can see the thrombosis at this level, pericardial effusion, periaortic hemorrhage here, so we have, that is very important, this information before managing the patient. But transthoracic echocardiography in the emergency room is also very important, because when arrives one patient with chest pain or some symptoms, to perform a transthoracic echocardiography is only 5–10 minutes. And if we can see this intimal flap or this aortic regurgitation with this flap protruding in the left ventricle, or this pericardial effusion, maybe we can change and active the suspicion of acute aortic syndrome. So transthoracic echo and computed tomography are maybe the best approach for a good diagnosis of acute aortic syndrome. This is the flow chart of decision making for the European Society of Cardiology guidelines. I partially disagree with this algorithm because they consider that with a transthoracic echo, with a clear definitive image of aortic dissection and ascending aorta, they send the patient to the operating theater directly. And I think that is justifiable only in unstable patients, but in stable cases, I think it's not logical. Maybe in stable cases, I will perform CT or MRI or transesophageal echo in order to know more information. So I think, in my personal opinion, this should be for unstable patients, and this should be for stable patients. But it's not required to send the patient directly to surgery when the patient is stable, only with transthoracic echocardiography. We will move the transesophageal echocardiography. I think it's not the best technique for the diagnosis. It's the best technique for the monitoring the treatment, for giving information for the surgeon, and before surgery we can identify what is the cause of aortic regurgitation, the etiology, and if it is required to change the aortic valve, what is the entry tear, what is the size of the entry tear, if there are secondary tears in the arch or in the proximal descending aorta. So I think the role of the transesophageal echocardiography should be in the operating theater. Malperfusion is a severe complication, and also CT is the best technique. You can see here that we will have a compression of the true lumen for the false lumen that generated a significant problem in the perfusion of the viscera and the abdominal viscera. So that is CT the best technique to differentiate dynamic obstruction that static obstruction. It's worse to have a dynamic obstruction and is required to act immediately and to try to close the entry tear or to reduce the high pressure of the false lumen, because that generated a systemic ischemia in all the vessels that are going to the viscera, as you can see here. We are moving now to the intramural hematoma. The first point that is curious in the two registries that the prevalence of intramural hematoma in the IRAD is only 6%, and in the RESA is 13%. In our hospital is more, is 16%. I think the problem is not other than the difficulty in the diagnosis. It's not so easy to diagnose intramural hematoma than aortic dissection. It's more complicated. So the first point is the best way to diagnose by CT is without contrast. You can see this hyperattenuation area can make the diagnosis of intramural hematoma. Here is more difficult with a novitis thrombus, or that is not a correct image. It's better before the contrast. For echo also is complicated. In some cases it's easy, but other cases with the novitis atherosclerosis, is a thrombus, etc., etc. And by MRI maybe is the best technique, but you know that MRI in acute aortic syndrome, 20 minutes, the patient there with claustrophobia, difficulty to control the blood pressure, etc., is not the best indication. So I think that intramural hematoma, the disparities are more related with the diagnosis than for other reasons. In addition, we published in the IRAD that 15% of patients with intramural hematoma, the intramural hematoma thickness was progressive. So, although MRI was the technique that diagnosed the intramural hematoma at the 8th day, here we didn't have a thickness of the aorta, but the patient presented pain and was sent to home, and the 5th day returned to the hospital, and also the CT didn't diagnose this minimum thickness, and after the thickness increased significantly. So there are some cases that the intramural hematoma is progressive. That is not typical for aortic dissection, but yes, for intramural hematoma. So if they are the first hours, maybe you don't have time to have enough thickness of the aorta to diagnose correctly the intramural hematoma. In addition, after the diagnosis of the intramural hematoma, the evolution is very dynamic. In the first month of the evolution, we can see here the intramural hematoma that is reabsorbed completely without any dilation. In the descending part, moves to the aortic dissection. And in this other case, the intramural hematoma evolved to ascending aorta dissection. So we can see that it's very dynamic. So the reason is that maybe the intramural hematoma requires a more control of imaging techniques because it's worse or it's more dynamic evolution than the aortic dissection. And that is the only way to diagnose that is by imaging techniques. The other controversial point is what is the best management of type A aortic intramural hematoma. There are several, I don't know many, but several studies from Asia that propose that the best management is medical treatment and only complicated cases should be indicated surgery. And in our opinion, that is not our experience in Europe nor in the States. So we think that it's important to stratify the risk of the patients considering the persistence of pain, the blood pressure, the periaortic hematoma, the intimal tear ulcer-like image as this one, maximum aortic diameter more than 50 millimeters, or the intramural thickness that maybe that is not the most exact predictor, more than 50 millimeters. But in these cases, we think it should be indicated surgery. Only in complicated cases should be indicated emergent surgery. The other can be indicated elective surgery, but in the hospitalization. So now we are moving to the predictors of the mortality in acute aortic syndrome. We can see here the type A predictors are the hypotension and shock, the migrating pain, perioperative cardiac tamponade, history of aortic valve replacement, and limb ischemia. That were the predictors in the IRAD for mortality in type A dissections. In type B dissections were the mesenteric ischemia, also hypotension and shock, acute renal failure, aortic diameter more than 55 millimeters, periaortic hematoma, limb ischemia, female, and age. But we can see really that the main predictors are the problems with instability, hemodynamic instability, and problems of ischemia or perfusion. That really is in A and B involvement. We are moving now to the last part of my talk, to the Spanish registry of acute aortic syndrome. This is the RESA 2. The first RESA was carried out 7 years before. Every 7 years we perform a RESA. We are now in the RESA 3. And I will show you the RESA 2 results. We included 620 acute aortic syndromes and participated most of the tertiary hospitals in Spain, 26 hospitals during these 2 years. And the first point is that the symptoms diagnosis interval, you can see here that around 80% of cases were diagnosed in the first 24 hours. 70% or 68% of cases were diagnosed in the 12 first hours from symptoms. And the median of this diagnosis in the first 24 hours was 5 hours. So I think the results are very good. And there are some subgroup of patients that the diagnosis was more difficult and arrived later to the hospital. But I think we improved significantly the interval between symptoms and diagnosis in current time. And we are now, the final slide is comparing the management and mortality. I include the RESA 1 in 2005-2007 and compared to the RESA 2, 2012-2014. You can see here, first of all, the management. The management in type A was very similar. We have 80% with surgical treatment and 20% with medical treatment. It's true that in this medical treatment there are intramural hematomas. There are patients that were more than some of the cases 80 years old, but really 20% is high in my opinion. And the important point is that the mortality, the surgical mortality is reducing from 34% to 25% during this period of time, so that is a significant reduction of the surgical mortality in type A intramural hematoma. If we compare that with the IRAD, we can see here that the IRAD also have a similar tendency from 30 to 20% of a reduction of mortality. Respect to type B, we have also that the mortality in RESA 1 was high, 23%, and reduced to 16%. In medical treatment was 16% and reduced 13%. And endovascular treatment at this time, the RESA 1 was 27% and reduced to 18%. If we compare with the IRAD also, we can see that it's very similar. The mortality is not reducing in the IRAD, it's very stable, and similar results with our RESA group also increased the endovascular treatment in the last 10 or 15 years. So my main lessons of the both registries is the high clinical suspicion is critical for an early diagnosis. The two lesson is the CT is the most used imaging technique for acute aortic syndrome diagnosis, and the combination of CT and TE is the best diagnostic strategy. Transesophageal echo is useful for guiding surgical and endovascular therapy. The interval between presentation and diagnosis has been shortened significantly. More than 80% of cases are diagnosed between the first 24 hours after symptoms onset with a median of 5 hours. Many aortas that dissect are smaller than our surgical cutoff points. This asks for better genetic biomarkers and imaging tests for correctly identify patients at risk, and that is a problem. And finally, that the diagnosis of intramural hematoma is more difficult than aortic dissection. Hematoma thickness may be progressive and evolution very dynamic, regression, aneurysm, or dissection. Intramural hematoma in the ascending aorta is a nasty disease that mirrors acute type aortic dissection. Emergent surgical treatment is indicated in complicated cases, and elective surgery in the non-complicated cases. The main predictors of mortality are severe hypotension and shock, mesenteric and limb ischemia, periaortic hemorrhage, or acute renal failure. Type A mortality is failing despite surgeon and aortic centers taking on more complicated and older patients. Type B mortality has been stable. However, thoracic endovascular aortic repair is replacing surgery for complicated diseases. Only time will tell whether it will be reduced, the mortality rate. Thank you for your attention.
Thank you, Arturo, for this excellent revision. We'll discuss after. Now, Dr. Martin Grobenwouwer is going to talk about how to optimize the surgical technique in order to improve the results. Thank you, Martin.
Yeah, thanks very much. At first, thanks very much for inviting me to this wonderful place. Dear Chairman, dear Chairwoman, ladies and gentlemen, my task is to talk about how can we optimize surgical treatment results in type aortic syndromes. So I want to focus now on this type aortic dissection where the intimal tear is located in the ascending aorta or in the aortic arch. And nearly in 60% of the patients, I think fast more, the tear is going down till the iliac bifurcation. The presentation of these patients is acute onset of chest pain, as we have already heard, which is very often confused with acute coronary syndrome. So we as surgeons received a lot of patients who are really anticoagulated with all the drugs we know. But the pain radiating to the neck and throat may indicate the involvement of the ascending aorta. In a lot of patients, you can have accompanied by aortic regurg, tamponade, as well as neurologic symptoms. Whereas when the pain is more focused in the back of the patients, it's more indicating there's a problem with the descending aorta, like a type B aortic dissection. There are guidelines of aortic disease. Of course, they say in patients with type A aortic dissection, urgent surgery is recommended. It's a class 1 indication, level of evidence B. We have already seen dissection membrane in the ascending as well as in the descending aorta. This is how it looks like if you open the chest. The only layer which is intact is the adventitial layer, and here this white thing is the intima media cylinder going up and down. This is also an intraoperative aspect of a dissected aorta. You see this adventitial layer and intima media cylinder, and here the intimal tear. It's in most of the patients, it's a transverse dissection of the intima media cylinder in the ascending aorta. So the question I was asked to answer, what are the engagement points to improve the results? The first thing is a rapid diagnosis and surgical treatment. As we have already heard from Arturo, I think the fastest way to diagnose a dissection is a TTE, transthoracic echocardiography. However, you see a dissection membrane in the ascending aorta, you have the clinical symptom of the patient. However, the surgeons, for the operative strategy, they would like to know more about the dissection, if the aortic, supraortic vessels are involved, if the dissection is going down to the iliac bifurcation. So for me, CT angiography is of major importance. During the operation, at the beginning, you can do, in addition, transphageal echocardiography, and the MRI plays a role in the follow-up, but not in the acute setting. So the next step, you have diagnosed a type A aortic dissection. It's a sophisticated surgical technique. There's only a few points. We have the topic of temperature management, how deep should we cool down the patient, the cannulation site, where should we connect our heart and lung machine, and then the extent of the operation. Should we operate only a small portion of the ascending aorta, or also replace the aortic arch or do even more? Only one slide concerning the temperature management. So the whole surgical community went now to cool down the patient to profound or deep hypothermia, which is below 21 degrees, more to a more warmer strategy. And in this work, Davide Pacini from Bologna, he compared two groups. Patients were cooled down below 25 degrees, and a group B, patients were cooled down only to 26 to 28 degrees. There were 194 to 110 patients. And you see that the group which were warmer, the group B, had better results. In this case, this was aortic arch replacement, 3.6% mortality, and neurologic deficit was even better in the warmer group. You have to take into account that all these patients received antegrade cerebral perfusion, so there is no circulatory arrest for the brain. And the conclusion was that moderate hypothermia is a safe method for brain protection and will end with good results. Where to put in our cannulas for the heart and lung machine. Also, from historically, all these patients were cannulated via the groin, via the femoral artery, so you have the retrograde flow. And nowadays, we are using the axillary artery, and in this meta-analysis done from a Chinese working group, at least we have 750 patients out of 9 studies, and you can see that a significant lower incidence of mortality, 6.7% versus 21%, can be seen in the axillary cannulation group, and the neurologic dysfunction with 14.3% was even less in the axillary cannulation group as compared to 26, which is very high, in the femoral artery group. So they concluded that axillary artery cannulation may reduce mortality. The operative technique in principle is tear-oriented. So the tear is located in the ascending aorta, and the surgeons have the task to resect the primary entry tear and to readapt the dissected layers here with Teflon felts or pericardial strips, or you can glue the aorta. However, the rest of the aorta, the distal ascending aorta, the arch, and the descending aorta remains dissected. You see these are CT scans after successful operation. Here you see the prosthesis. And here, distal from the prosthesis, the aorta remains dissected. And in most patients, the proximal part of the descending aorta starts to increase in diameter and makes problem thereafter. Like you see here, this is not a dissection, but also a very brave surgeon make a very large replacement of the descending aorta, and this patient also ends up with a lot of problems afterwards. So you have a chronic type A dissection afterwards. And this will have, this you can see, you have malperfusion, you have chronic dissection of descending aorta, chronic dissected aortic arches with increasing aortic diameters in the future. And we do have a problem with these aortas. These are nearly 20 years old, these articles, Rosella Fattori, Baron, Park from Korea. They all have the conform results that in these patients you have nearly in 70 to 80% you have a patent false lumen in the rest of the aorta. And nearly 30% of these patients, they need reintervention up to 5 to 10 years after the successful operation. And the patent false lumen is a significant risk factor for increased aortic diameter in the descending aorta. And when the false lumen is thrombosed, you can achieve a shrinkage of the aorta. And all these patients, the most common cause for late death is related to the distal aorta. So this was operated in my unit. This was, we were in follow-up, 5.5 centimeter, the dissected descending aorta, and this aorta ruptured here, and he has to be operated in an emergent way. Also another work showing us that a patient with a patent false lumen at descending aorta has a much worse outcome. Survival at 10 years. In this manuscript, 89% for patients with an occluded false lumen versus 59% for patients with a patent false lumen. So what can we do? And here's now my favorite product. It is called frozen elephant trunk. It's a hybrid procedure, a hybrid product. It's a combination of an endovascular stent graft with a surgical dacron prosthesis. And why should we use this? To promote thrombosis of the false lumen. So you can use this hybrid prosthesis to stent the true lumen of the proximal descending aorta. Thereby you can close re-entries in the descending aorta. The arch is replaced in the ascending aorta by the dacron prosthesis. And thereby you expand the true lumen, and also you can facilitate consecutive surgical or endovascular procedures of the descending aorta because you have this stent in the true lumen of the proximal descending aorta. And the goal of this hybrid procedure is to decrease reintervention rate and improve survival in the long-term run. This is an angioscope, circulatory arrest. You're looking down into the descending aorta, because during operation we cannot use an X-ray. You see here, this is an entry tear in the descending aorta. This here is the intima media cylinder. The true lumen is here on the right-hand side, 2 o'clock, and the rest here is the huge entry tear in the false lumen. So the goal of the operation, you stent the descending aorta, and by surgical technique, you replace the arch and the ascending aorta. You use this from Jotec, these Germany produced hybrid prosthesis. And the surgical technique is we insert the stent graft in the area of in the period of circulatory arrest in the descending aorta. No X-ray under direct vision because the landmark for stent graft placement is the offspring of the left subclavian artery for where we place the end of the stent graft directly at the offspring of the left subclavian artery. To control if we are in the true lumen, if it is well positioned, we can use an angioscope, as you have seen before, to control the placement of the stent graft. And then the stent is sutured to the proximal descending aorta, and then the dacron prosthesis is pulled out, and the arch and the ascending aorta is replaced. We are, as I've already mentioned, we're operating in moderate hypothermia, 25 to 28 degrees, not in 18 degrees Celsius. The arterial cannulation is in most patients a right subclavian artery with an interposition graft. Is the right subclavian artery cannulated, and we are performing bilateral antegrade cerebral perfusion with approximately 700 to 1,500 milliliters antegrade perfusion. So at the end, the brain has no circulatory arrest. These are some intraoperative pictures. This head of the patient is on the left side. This is the aortic arch open. The ascending aorta is already resected, and here the stent graft is inserted. This is a cannula for antegrade perfusion of the left carotid artery. This is a Fogarty to occlude the left subclavian artery. And then the supraortic vessels are here, and this is the proximal descending aorta. Then everything is sutured to the descending aorta. And then we have the stent graft and descending aorta. Then we pull out the dacron prosthesis. We cut a hole here, and then we reimplant as an island or the supraortic vessels in these arch prostheses. And so you will end up, here's the reimplantation. We have a stent and a descending aorta, a prosthesis in the arch as well as in the ascending aorta here with one piece. In this patient, we had made a separate prosthesis for the ascending replacement. This is a little look, this is blood. This is a patient with an acute aortic dissection, circulatory arrest, the innominate artery is clamped, and unilateral antegrade perfusion. And now in a acute dissection, you can discriminate very well between true and false lumen because it looks different. And over this pigtail catheter, we insert an extra stiff guide wire, and over this extra stiff guide wire, we insert now these hybrid prostheses. The sheath is retracted, the stent graft is deployed, and you see here, this is the yellow line, this is the left subclavian artery. And here you have we cut it now a 1 centimeter rim and suture now the dacron to the proximal descending aorta. And here also against the rim of the left subclavian artery. This is dissected material, so we have a dissected aorta. At the inside we have the dacron material. At the outside you have a Teflon felt strip, and this is a very safe anastomosis for a dissected material. And then at the end, after we make that distal anastomosis with a very oblique, tailored dacron prosthesis. And at the end, then we remove this clamp, we de-air the whole thing, and you see here, then we clamp again, and then the whole arch is replaced as well as the descending aorta. It looks like the ascending aorta, prosthesis, endograft. So you push the dissection down. Of course, distal, the dissection remains, also in this case. This was a type B dissection, but it's possible to occlude the false lumen at least till the end of the stent graft. Makes it sense. Here a work from a Japanese working group. They compared two groups, in total 120 patients, and that they could show that there is the event-free, after 5 years, the event-free survival for the frozen elephant trunk group was 95%, whereas it was only 73% for the hemiarch group, and the survival was also significantly better. Also in this meta-analysis, you show that the frozen elephant trunk procedure will end up with very good results. False lumen thrombosis 69.8% and early mortality 9.2%. So last point is team trained in the management of complex aortic disease, which means you need a patient volume and you need a technical armamentarium. And also one article dealing with quality improvement of thoracic aortic surgery, estimating volume outcome effect from national wide survey. And you can see that an increased hospital volume was associated with reduced mortality rates in patients below 65 and in high-class risk surgical candidates. So we need an aortic team cardiologists, surgeons, anesthesiologists, radiologists, perfusionists have to work together. We need a volume, a caseload to obtain good results. And then I come to my conclusion that moderate hypothermia, bilateral antegrade perfusion, axillary artery candilations are the cornerstones of type A repair in Europe. Hybrid procedures like this frozen elephant trunk technique widen the armamentarium of cardiovascular surgeons in the treatment of this complex disease. And the frozen elephant trunk technique is very good in enhancing thrombosis of the false lumen, and so we will have less reinterventions in the follow-up and better survival. Thank you very much.
Thank you very much, Martin. The last speaker is Professor Christoph Nienever, cardiologist and interventional cardiovascular specialist. His work at Royal Brompton Hospital, his research and clinical activities are focused on the diagnosis and non-surgical treatment of acute and chronic aortic pathologies, such as aneurysm as an aortic dissection. He is the co-founder of the IRAD, which operates as a global network for acute aortic conditions. Through this, he has pioneered new endovascular techniques to treat aortic dissection and initiate and participate in guidelines. Today, his talk is when medical treatment is not enough in type B acute aortic syndromes. Thank you very much, Christopher.
Thank you very much, Rosa-María and Alberto, for having me here in beautiful Santiago de Compostela. It is really a pleasure for me to discuss this important issue with you, and forgive me that I changed the wording a little bit and turned it slightly around by adding under which conditions can we today justify medical management alone in these patients. I think we heard already by Martin what's happening in Japan. And this is a very important slide, I think, because looking at the demographic evolution in Japan, which is about 15, 20 years ahead of us in terms of demographic evolution, you will notice easily that the amount of aortic conditions here in red is increasing over the years. This is 2013, it's probably even more now. Coronary artery disease is on the decline, valvular disease is also increasing, and congenital is staying the same. So we're facing more aortic conditions in the near future, in the next 15, 20 years, as they already see in Japan. And if you look at type A and type B dissection, the mortality is now going down over the years, over the decades, but the amount of patients in red that die from these conditions are still quite substantial, although the number in percent is decreasing because we see more volume. But we have to face this volume and treat it appropriately. This is a model of hemodynamic stress and aortic conditions with an image below here. Unfortunately, it doesn't move, but it should show that the amount of shear stress on the aortic wall is highest in areas of increased dilation or dilatation in pre-disease segments of the aorta. And the point of medical management is to decrease that local wall stress by lowering DPDT, by lowering affected wave refractions, and of course, by some sort of negative inotropic action of our medication that we can use for aortic conditions, in dissection in particular. So antihypertensive therapy, as mentioned in the guidelines from 2014, has only the goal to decrease the local force, the local stress on the dissected aortic wall. And if you look at the guidelines, there's multiple of them in Europe, in the US, in Japan, in other parts of Asia. They all look at IV beta blockers in as a first-line medication in order to decrease that local shear stress. And there's one very popular IV beta-blocking agent, labetalol, that you can use in the emergency room once you have established a diagnosis. A little bit funny is to achieve a heart rate of less than 60 beats per minute. There's no evidence whatever to show that this is beneficial. It is probably logical to decrease systolic blood pressure to 100 or to the least tolerated amount of blood pressure in a patient in the acute setting of a dissection, as long as adequate organ perfusion is preserved. You can use actually any other component if beta blockers are not available or not tolerated. There's no restriction of whatever you use in terms of lowering blood pressure. And of course, a combination of these medications, including beta blockers or ACE inhibitors or ARBs, is also welcome. Once stable, and this is a quote from the guidelines, transition to oral medication and continuation long-term is recommended. But what is the evidence for these recommendations? If you ask for evidence for these recommendations, you will find nothing. There's not a single randomized controlled trial to prove that antihypertensive medication or any kind of these medications is helpful. The best data I could find in the literature is here. It's actually a small study on 188 patients looking at the freedom from reoperation after previous type A dissection, which obviously is better if you lower blood pressure by use of beta blockers as compared to no beta blockers. Very, very rough and simple differentiation. I can believe that you fare better with a lower blood pressure, but how low should the blood pressure be? This is a sub-analysis from the same quoted paper that I just showed you from France, Melby, showing that only if your blood pressure is in the range of less than 120 systolic, 3 out of 85 patients achieved that, then your long-term outlook is probably okay. If you reach only between 120 and 140, you end up on this curve, and if you can't really control blood pressure, it's over 140, then your outlook is grim, as you can see. 25 years follow-up after surgery. And the best you can achieve is shown here. A patient under medical management in order to prevent rupture, aneurysm formation, and later repeat aortic repair or aortic repair as a first step, under medication shows over 5 years no rupture, no death, but an impressive increasing diameter of the false lumen and the true lumen slightly over the years under medical management, which actually should have been prevented by medical management. And this is another example that shows you 5 years on drugs with a type B dissection. This is very difficult to repair, and I think simple solutions using endovascular strategies is difficult to apply. This obviously needs an open repair at the chronic phase of dissection. And again, I think this is really sobering to look at the various pieces of evidence in the European, in the Japanese, and the US guidelines. They all come up with a 1C recommendation. In other words, they all believe that it's good to lower blood pressure, but they have no evidence. It's always a C. This is another important slide that I came across recently, showing what happens to patients if you follow them under medication only, trying to achieve a normal blood pressure, or if you send them to surgery in the proximal aorta or to endovascular treatment in the distal or descending aorta. Look, with medical management alone, achieving a reasonable blood pressure control, the outcome is, of course, half as good as with additional surgery or endovascular treatment. Very reassuring that you should not use medication only in a case of type B dissection. Allow me to introduce this kind of pragmatic classification in acute aortic syndrome. I was supposed to talk about complicated and uncomplicated, and stable and unstable, and who needs actually medication and who needs more, or who can justify only medication. I think it's very helpful to divide our patients in 3 groups. One called the complicated aortic syndrome, which implies even proximal dissection or intramural hematoma. We heard about this. Any kind of evidence of malperfusion, imminent rupture with extra-aortic blood collection, or other features. We go to this in more detail in a minute. So any kind of complicated acute aortic syndrome, I think, needs attention, active attention by surgery in the ascending or endovascular treatment in the descending. This is an example of a malperfusion case, another feature of complicated type B dissection here. This needs to be treatment. Medication here is not enough. The right leg is in danger. The left kidney is not perfused anymore. So this needs active attention. IRAD has been mentioned. This is a very important slide from IRAD that looked at type B dissection only. And they divided the so-called high-risk feature with hypotension, shock, and imminent rupture to the low-risk feature. High-risk feature, of course, we learned that already, need immediate attention because the body isn't perfused properly or the organs are not perfused properly. There's no perfusion to the lower part of the abdomen here or the legs, which opens up with a stent graft here, as you can see. But more importantly, and we'll talk about that later, the low-risk group is even more important. This is, again, a recent publication from Mass General Hospital in Boston. They looked at all patients with type B dissection in a complicated presentation with malperfusion or imminent rupture. And if you stent them upon hospital arrival or within a couple of hours, you can present an almost plateauing outcome curve. These patients do not rupture in the next couple of days or months or even after a couple of years because they are stabilized early on in the setting of a complicated dissection. Very reassuring that you can stop this process of ongoing complications early and late by an early or timely intervention. Let's now move on to patients that do not show these complicated features, but rather other features, such as blood pressure is not well controlled, episodes of pain are reoccurring, the false lumen has a tendency to expand over 4.5. It's not 5.5 anymore, it's now 4.5. There is also rapid expansion within a couple of weeks. Single entry tears, particularly if they are large. Arturo Evangelista has shown that in his cohort. True lumen collapse, even without clinical signs of malperfusion, and ongoing inflammation. Those features can be identified in the subacute phase of any dissection easily by imaging. If you identify these features, and I'm going to show you some, then you can separate among those so-called low-risk group various patients that do not fare well with only medication. So you have to look at this particular subgroup in more detail by looking at the risk factors that I just mentioned to you. On average, 5-year outcome of these so-called low-risk but patients with features of high risk is 40%. So 40% of them are dead by 5 years. Here it is in more detail. Santi Timaki published this from IRAD, 17% mortality if there's refractory pain, ongoing pain, and no sustained control of hypertension qualifies for very high-risk outcome on medical management alone. So it's very important to be sure that you can control pain, that you can control blood pressure in the acute or subacute phase of any dissection. So if that's not the case, the patient automatically qualifies for more intervention, probably endovascular or even open surgery. This is a very iconic curve from Korea. They showed early on in 2007 that patients with a rapid expansion within a couple of weeks of the false lumen of the affected aorta fare badly. You find them here on the red curve, whereas others that do not expand and show a stable course over the initial couple of weeks end up on the blue curve, which is a better outcome or more, almost stable outcome in the acute situation. Another important feature and observation from IRAD was the detection of false lumen thrombosis. Here, as you can see, a rim of thrombosis in the false lumen indicative of a high-risk setting because obviously the flow is low in the false lumen, the pressure is, particularly the diastolic pressure is high, and you have no outflow. And that settles for thrombosis, which identifies a high-risk subset with an elevated diastolic pressure in the false lumen, which, again, is prone to rupture. Again, we mentioned before the size of the communication is important. If you're dealing with large sizes and large entry tears, a patient needs to be treated actively by surgery or by endovascular. And there's reasonably recent information on an ongoing inflammation or signal of ongoing inflammation based on FDG uptake on PET. If that's the case, patients do better and fare well and better with an endovascular approach in order to pacify the inflammation, which is not infection, it's an inflammation, ongoing metabolic activity. And based on these pieces of evidence in IRAD, unpublished data so far, we know that active and complete false lumen thrombosis induced by an endovascular treatment or induced by surgery has a high odds ratio for a stable outcome with 5.3 or 5.4. In other words, patients that thrombose their false lumen and stabilize over the years or remodel fare well. They have a stable outcome curve as compared to patients that do not remodel because their false lumen is not completely thrombosed and that actually are prone to further complications and expansion and eventually rupture in the future. Let's spend a few moments on patients without these high-risk features. You can probably estimate or assume that patients without these before-mentioned high-risk features are probably candidates for medical management alone, because obviously medical management and blood pressure control could be enough. We looked at this in the randomized INSTAT trial and found that both patients with no high-risk features, treated either with medication only or with an additional stent, did well in terms of outcome, but after 2 years there was a crossover, because among these patients under medication only, that we saw a significant amount of patients that expanded their false lumen and eventually ruptured. We followed these patients even further, beyond 2 years, up to 5 years, and could show that, again, what we saw already in the complicated cases, even those so-called low-risk patients have an ongoing attrition and complications if they are not stented as compared to those that had been stented early on, despite they were considered low risk. So the stable course as compared to an ongoing attrition. The same signal emerged from IRAD, from a Chinese registry with more patients, of course, but exactly the same result, showing that edge for endovascular treatment, in patients, although they were considered good candidates for medical management only. And more recently, 2015, the group in Boston published, again, TVAR endovascular treatment for uncomplicated patients. Shows exactly the same result, a stable long-term outcome, as compared to those patients that are considered to be candidates for medical management only with an ongoing attrition rate. You have to wait 2 years before this becomes clear. After 2 years, the curve separates, so you basically invest into the future by an early endovascular treatment in those low-risk patients. But why not offer a patient something like this, a remodeling of the entire aorta, if you can do that safely and if you can offer this service in a safe way? If you look, again, data from IRAD, what happens to those stable patients, low-risk patients over the time, and you can see here limb ischemia, rupture, late complications and extension, all that happens late, unpredictable, although you believe the patient is okay. We recently looked into the published evidence in the literature and found, again, by comparing conservative management with drugs versus endovascular and open in type B dissection, and could show that in the setting of medical management alone, up to 55% of medically treated patients develop aneurysmal degeneration over 5 years with an unknown risk of rupture. The guidelines actually support active treatment. If you look at the European guidelines, uncomplicated type B dissection has a 2A recommendation with a level of evidence B to actively treat them in addition to drugs with endovascular treatment. Similarly, the European Society of Vascular Surgery had a similar statement earlier in 2017, coming up with a conclusion that they should be actually selected for endovascular treatment based on anatomical suitability, but generally go forward with endovascular treatment. Finally, what we are doing now in those patients with a relatively low risk, clinically completely stable, no symptoms anymore under medical management, we subject them to a risk analysis based on images alone. This is a very benign looking type B dissection, as you can see, no expansion, good flow, no problems. The patient goes home after 2 weeks. But we can use data from the images now, quantitative data from the flow images and the anatomic features of this type B dissection, put it into a risk calculator, and come up with a particular risk factor or risk prediction of this very patient who looks benign with a 22% mortality risk in 2 years. This is more recent information from Stanford. They published this last year, and we're using this risk calculator now for our stable patients. So, in summary, in 2018, in other words today, every patient should receive medical management. It's a no-brainer. But that is almost never enough. We can qualify and quantify our patients. We can analyze risk factors and constellations and can come up with a list of complications that all need to be excluded if you justify the patient only on medication, only on drugs. And finally, the additional help of this risk calculator can give you a relatively safe prediction of the risk in the next 2 years, which is surprisingly high, as we saw in our little example. Finally, I want to leave you and open the discussion with my final slide that shows you our group, where we work together and plan our cases and our treatment strategies together. And it's really an example of good collaboration between surgeons, cardiac surgeons, vascular surgeons, imaging specialists, cardiologists. And we do that basically every week, twice, and are now facing a volume of more than 50 endovascular cases and about 250 surgical cases over a year. Thank you very much for your attention.
Thank you very much. Arturo, Martin, just we have very short time for discussion, maybe 1 or 2 questions. You can come here.
We have moved to acute aortic syndromes from chronic aortic syndrome. That is a very exciting question. What happened with the patients after the acute aortic syndrome? For example.
Yeah, I think it's a very intriguing question. What happens to the patient after the acute presentation? Is this on? The acute phase is, I think, the phase in the hospital, the initial 24 hours up to 1 week is usually considered the acute phase. And that is a phase that you should use as physicians to stratify your patient and identify those risk factors. After that 1 week, it should become clear who needs immediate attention, who needs to be called back in a couple of weeks for an elective procedure or elective surgery. But I think it's vital to use that initial week in the hospital to stratify your patient properly. And then the patient has a history of acute aortic dissection or acute aortic syndrome, but he has more than this history. He has actually presented with acute pain that is settled, but he needs to be stratified. I think that should be the message for the hospital admission, that the patient needs not only to be diagnosed, but also to be stratified.
Okay, I have a question for Arturo and Martin. Why do you think there are big difference in mortality in registries, for example, the IRAD or RESA, and compare with specific reports of specific centers? It's patient selection or excellent centers, and do you think this should we change the referees of this patient to specific hospitals? What do you think?
Yeah, I don't know if it works. Yeah.
It works.
I think that that is the reason. In IRAD are only at the beginning, maybe now also the group of hospitals experts in aortic disease. In RESA are included all the hospitals in Spain that they accepted to participate, considering the rules that we define. So there are experts and non-experts. And in specific publications of one center, always are experts. One point to analyze when you try to understand the results is to consider the interval time between symptoms and surgery. Because when you delay the surgery, you have better results, because many patients died are not included. So the period of time in the diagnosis, or the present of symptoms, diagnosis, and including the patient for surgery is worse for the surgeon, because they include benign cases, but more malign cases are included there, so that they have more mortality. I think the reality, we try in the registries to show the reality and not to show the expertise of the team. That is my opinion.
My opinion is...
And one more question for you. And in your hospital, this surgery is performed by on-call surgeon or by any, I mean Martin, it's for Martin.
You.
It's performed not always by the surgeon. He's on duty in the hospital, but we have 3-4 surgeons specialized, and then we are calling us and coming and helping. Maybe he's not an expert who is on duty this night, and then we are coming and doing this case together. But my answer is similar. The first thing is the patient selection. In Japan, they have very good results, but we asked the time between onset of symptoms operation is in some centers 3-4 days, and in China too. So there's a natural selection of the worst cases. So we also always fight. In my unit, I had the words of Greg Miller in mind: don't perform warm autopsy. If a patient with a type beta section is under resuscitation and the lactate is high, don't go for operation. The next thing is malperfusion. If you have a visceral malperfusion, they have to maybe do different things than go for a regular operation, but nearly all patients are dying with a severe visceral malperfusion to go for a regular operation. So the first thing is patient selection, and your answer, because in the studies the results are better than in registries. For example, in the frozen elephant trunk trials, there are 3-4 expert centers, and of course the patient who receiving a frozen elephant trunk are selected. You will not do an 85-year-old patient in shock a frozen elephant trunk procedure. So if you go in the real world, you will end up maybe with 20%, and the selected special cases you will end up with maybe 8 to 12%.
Thank you very much. We must close this interesting session. There are a lot of questions, but it's not possible. And the next round table, it's coming. Thank you very much.